and welcome to the Medi Classes postgraduate lecture series on acquired hypothyroidism. Over the last 2.5 years, we have been working on different modules related to pediatric endocrinology, and the PG lecture series has covered many like growth, calcium, electrolyte, along with thyroid and pubertal disorders. So we are going now towards acquired hypothyroidism. And acquired hypothyroidism is one condition which is quite common from a pediatric perspective and something which has significant implications in terms of short and long terms from different aspects, not just growth, but puberty, but many other issues. It can also be a cause of emergency, as was seen in this case. This was a 12-year-old boy who had presented to us with poor school performance. And at that point of time, he was found to have a low FT4 and a TSH of 9. At that point of time, the treating physician considered that this is a hypothyroidism. It's more likely to be a primary hypothyroidism because TSH is slightly high and started on thyroxine. But within a couple of weeks, the child developed hemodynamic instability and shock. And what really went wrong here was that there was an erroneous assessment in terms of thyroid function. In that, when we remember that whenever the FT4 levels are low, we expect the TSH levels to be very high. If they are not high, this suggests a central hypothyroidism. So this was a central hypothyroidism with associated multiple pituitary hormone deficiency, which was missed and resulted in this abnormalities in terms of treatment. So clearly, this is one condition which is quite common, but often can cause a lot of confusion in that perspective. So this is a rare form of acquired hypothyroidism. We'll be discussing a lot about this in that regards. All of you can go and have a look at our website learning.growsociety.in, which has got multiple sources and resources regarding pediatric endocrinology, our e-learning platform, our courses which are there, along with our fellowship and pediatric endocrinology for postgraduate courses. We run a number of activities every month, including this PG lecture series, grand rounds, and journal clubs. And we have multiple publications ranging from pediatric endocrinology protocol to basic and advanced pediatric endocrinology. And our app provides comprehensive assessment of pediatric endocrine disorders, including thyroid interpreter, which is also available. So today we're going to focus about acquired hypothyroidism. So acquired hypothyroidism could be primary. The most common cause is primary, where your TSH is high. Most common is autoimmune. Others could be really infiltration, iodine abnormalities, or radiation damage. It could be secondary or central because the problem in the TSH receptor, multiple hormone or TSH beta, and finally you can have a thyroid hormone resistance because of either the MCT8 problem, the monodiiodinase problem, and here again you will have high TSH and T4.
Acquired hypothyroidism causes can be transient, which include non-thyroidal illness, obesity, iodine deficiency or excess, which is can be due to amiodarone, drugs like anti-thyroidal drugs, lithium, anti-epileptic drugs, tyrosine kinase inhibitors, or interferon alpha. There is a permanent cause, of which the most common is the primary hypothyroidism, among which the most common cause of primary hypothyroidism being autoimmune causes, which include APS1, APS2, isolated causes, or IPEX, associated with IPEX syndrome. It can be a missed congenital hypothyroidism, either dysharmonogenesis, hemiagenesis, or pseudohypoparathyroidism, or insult due to radiation or a surgery, or associated with any syndrome like DJOT syndrome or Prader-Willi syndrome. It can be a central cause, which includes MPHD, thyroid receptor hormone defect, or TSH beta defect, or impaired action of thyroid due to resistance to thyroid hormone action, MCT8 defect, or increased consumption as seen in hemangioma. The primary hypothyroidism, there is a decrease in T4, resulting in increase in TSH and further increase in TRH. The increased TSH will act on FSH receptors, resulting in development of ovarian follicles, which can present in girls with precocious puberty and in boys with macroorchidism. The TRH, which is increased, will cross react with prolactin, and there will be increase in prolactin levels as seen. Therefore, the effect in primary hypothyroidism is increased TSH, low T4, low T3, and low free T3 levels. The 95% of the cases we see are primary hypothyroidism, in which there is the first rise in TSH is seen. Then T4 and the role of T3 is very limited in diagnosis of primary hypothyroidism. The most common causes being autoimmune, iodine deficiency and excess is seen, and insult with radiation or surgery or is the common causes of primary hypothyroidism. Autoimmune thyroiditis can be two types: atrophic thyroiditis or a goitrous autoimmune thyroiditis. Atrophic thyroiditis is a uh, cell mediated immunity due to thyroid receptor blocking antibodies, which results in shrinking of the size of the thyroid gland, resulting in atrophy. And could be a autoimmune thyroiditis, which is also T cell mediated due to thyroid stimulating in antibody or thyroid inhibitory antibody. It can be both, or TSH antibody associated. The 50% of the cases have goitrous, rest are atrophic variant. The TPO positivity seen in children with normal thyroid function, there is 10% chances that they will progress over 5 years duration. Therefore, only TPO positivity is not treated.
So this is an important because a lot of patients are referred to us with TPO positivity. So the chances you do annual TSH will be recommended in that regard.
uh, thi- uh, Thyroiditis in general is association with in general population 6% are TPO positive and 10% are thyroglobulin positive. 3% of thyroiditis is associated with beta cell immunity, and less than 1% is associated with adrenal immunity. And there's also association seen with celiac and pernicious anemia. Therefore, there's no routine screening is required, as the association is less than 1%. Only screening for type 1 diabetes or adrenals is done if there are symptoms like vitiligo, pigmentation, polyuria, or GI symptoms. And if there is increased requirement of thyroid hormone, the child should be screened for celiac disease. Thyroid autoimmunity, celiac disease have 10 to 20% of autoimmunity, and we should follow up annually for thyroid disease in celiac. Type 1 diabetes have 20% TPO positive and 5% are hypothyroidism. Should screen at diagnosis and then followed up at 1 to 2 years. Down syndrome had 28% antibody and 20% are hypothyroidism. Should be screened at 0 months, 6 months, and 12 months, and then annually. Turner syndrome, 15% of them have a thyroid autoimmunity, and more is seen with iso-XQ chromosome, and they should be followed up annually. Klinefelter syndrome, 10 to 12% should be followed up annually, and APS1, 10%. Annual screening should be done, and APS2, 70% of them have chances of thyroid autoimmunity and should be followed annually.
So while you don't need to do other screening in somebody with hypothyroidism, if somebody has other autoimmune, thyroid is done in everybody. So this is a general principle that if your disease is very common, you don't screen. So you screen only for disease which is rarer than it.
Mm.
Then you will do it for everybody.
IPICs, 50% and should be screened at diagnosis and annually. Thyroid hormones are damaged due to radiation effect, which can be a scatter radiation given or a cervical radiation given, or it can be affected by tyrosine kinase inhibitors or chemotherapy like busulfan if given. Uh, it can lead to hypothyroidism, most commonly in 60 to 70% after radiation effect, which is progressive and can be detected early. Can present as thyrotoxicosis if the radiation dose is very high, more than 35 gyri, which is transient, and it is due to cell mediated immunity. Can present as thyroid nodule, which also occurs with 20 to 30 gyri of radiation when given. Can be monitored with neck palpation on anybody with on radiation. Ultrasound can also be done. Management should be done as per the guideline of thyroid nodule. Treatment of subclinical hypothyroidism should be done in a child receiving radiation to avoid tumorigenesis in them.
I think that's a very important point. Anybody who has had radiation or is predisposed to a thyroid cancer, you need to keep TSH as absolutely normal or a low level. So hypothyroidism should definitely be avoided. So this is one subclinical with its absolute indication to start thyroid.
So, syndromes associated with hypothyroidism, D. George, there is 25% prevalence of having hypothyroidism. It presents with hemiagenesis. There are other features which help in more diagnosis of D. George, like hypoparathyroidism and cardiac defects. Williams 32%, which is reversible. Prader-Willi, 4% of them are primary hypothyroidism, 7% of central hypothyroidism is seen. Central hypothyroidism occurs when there is decrease in T4 and T3 levels, but not substantial increase in TSH as compared to the decrease in levels. Uh, there is low TSH, TSH, low T4 and low T3 levels. It can be isolated or associated with MPHD. Uh, the diagnosis is made on low T4 or normal or low TSH, which is the bioinactive form of TSH which is present. It could be due to TRH receptor defect, TSH gene defect, or MPHD, or malformations which is associated with HESX1, PIT1, PROP1 gene. Tumor, trauma, or infection can lead to central hypothyroidism. Consumptive hypothyroidism, there is more activity of DIO3, which results in more conversion of T4 to reverse T3, seen in case of hemangioma. It is associated with more increased requirement of thyroid hormone and high reverse T3 levels. And high treatment is with high dose of thyroxine, or we can give high dose of thyroxine, or we can give some. Go back.
You can use either high dose of thyroxine, or you can go ahead and use T3 also, which is now available.
TRH receptor defect. There are two types of TRH receptors, as told by sir, TRH alpha 1 and TRH beta 1. The most common being TRH beta 1 defect, which presents with irritability or hyperthermia. On lab parameters, there is high FT4 and high FT3 with normal TSH. Treatment is by beta blockers, or thyromimetic can be tried.
I think this is very important to remember that there are two different receptors. So if one is not acting, your entire function will shift to the other side. So you will have features of both hypo and hyperthyroidism. So people used to call it earlier pituitary resistance to thyroid hormone or peripheral resistance. Now we know it is because of the subtype of the TSH receptor which is there. So again, very important. So what you can do is that you can use the agent which is going to bypass this process. So Triac, which is used in that regards. Yeah.
MCT8 receptor defect. It is an X-linked defect. It is result in impaired thyroid transport. It presents with hypotonia, spastic paraplegia, dysmyelination. And on lab investigation, there is high T3, low T4, and mildly high TSH. Can be treated with Triac, and fetal treatment is required.
So this is a very, very important condition, and this is one condition. So I had told you that T3 has got a limited role, or it is useless in the evaluation of primary hypothyroidism. But this is one condition where T3 will be very helpful. Now remember, these cases will not look like hypothyroidism. They will look like more like a neurological involvement. So if you think of somebody who is severely neurologically deranged, in that setting, T3 also should be done, because otherwise you may not pick it up much.
Non-thyroidal illness. During illness, the levels of MDI3 increases, and there is decrease in MDI1 activity, resulting in more levels of reverse thyroid hormone and decreased level of T3. In brain, there is increase in MDI2 activity, resulting in more levels of T3 and then suppression of TSH. This is basically a protective mechanism during illness, which is supported by high levels of cortisol and cytokine levels during illness. Uh, the raised T3 in the brain will suppress the TSH levels. The dopamine also inhibits the TSH, and the cortisol also have a direct inhibition to TSH levels, resulting in reduced TSH, and the cytokine produced during illness will inhibit TRH, so resulting in reduced TRH levels. Therefore, during illness, we find low TSH, low T3, and a low T4 levels. During recovery, the activity of MDI1 increases and MDI3 activity decreases, resulting in increase in T3 levels and decrease in reverse T3 levels. In brain also, there is increase in T3 levels, and hence there is seen of high TSH levels seen during recovery. However, the level of rise of TSH is more compared to the rise of T4 and T3. Therefore, during recovery, we see high TSH, low T4, and a normal T3 levels. So we should avoid screening for thyroid during illness, and if any abnormality found, it should be followed up after 3 weeks. And treatment should be done only if TSH is more than 10. A non-thyroidal illness, the assessment should be only be done if it is essential with free T4 and TSH levels. T3 and T4 are optional. uh, TSH levels are low during illness. Assessment is same as low. Significant when TSH is very low, less than 0.01, or TSH is more than 10, then it should be treated. It is highly sensitive marker. T4 levels are low, assessment is lower. Significance if the T4 levels are high, and we should track and follow. FT4 levels are low during illness, and assessment is variable, and there's an unclear significance of free T4 levels, and we should avoid doing them. And T3
Either if you're doing it, then you should do it using equilibrium dialysis, which is not available in most centers.
T3 levels are also low, and assessment is variable and unclear significance of T3 levels, and we should track them if found low. Obesity, there is a lot of adipocytes present in obesity, which result in increased levels of leptin, which causes increased expenditure of body metabolism, resulting in increased TRH and increased TSH. And but there is normal T4 levels. So obesity, we found high TSH, normal T4, and a normal T3 levels. It is a compensatory mechanism of a body to increase resting energy. It is reversible and no treatment is required. Drugs which causes hypothyroidism are phenytoin and phenobarbital, which inactivates thyroid hormone. Lithium causes impaired release of thyroid hormone. Dopamine and steroid causes TSH inhibition. Tyrosine kinase inhibitor and interleukin 2 affects the thyroid production. Amiodarone affects the thyroid hormone by iodine excess. Valproate causes central hypothyroidism like picture. Subclinical hypothyroidism, when there is judge when there is FT4 levels are normal and TSH is between 6 to 10. The cause can be autoimmune or TSH receptor antibody. It is has high chance of remission, and treatment is only done if TSH is more than 10 or TPO positivity in 6 to 10. Trisomy 21 abnormality can be dysgenesis or autoimmunity. There is a low normal FT4 and a high normal TSH is seen. Plan is to treat only if TSH is more than 10. And screening should be done at birth, 6 and 12 months, and then annually. It
And
should
the
be followed.
problem in trisomy 21 often is that you will have fluctuating course. Sometimes they have hypothyroidism, then thyrotoxicosis because they have got dysgenesis, autoimmunity, everything going on. In which we like to go, all of you to go and have a look at our website to look at different aspects of pediatric endocrinology, look at the books, the publication, the mobile apps, and we will join again in a couple of months with the subsequent aspect.